Good evening, everyone. My name is Jen Nolan, and I'd like to welcome you to the 9th webinar in our 2016 Musculoskeletal Health webinar series, and the 5th webinar is Move Muscle, Bone and Joint Health, the new dynamic voice of arthritis and osteoporosis Victoria. This evening's webinar will examine an evidence-based approach to the prevention and management of osteoarthritis. Before introducing our presenter for this evening, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the webinar organiser at Redback Conferencing. If you are listening via the phone, you'll notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenter will answer questions possibly during the presentation or certainly after the completion of his presentation, you can actually type questions for him at any time. Can I suggest that you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Standard Time. I'd also be very grateful to all participants if you could take a moment at the end of the webinar to complete the exit survey. It should only take you a moment. Our presenter for tonight is Professor David Hunter. David is a rheumatology clinician researcher whose main research focus is clinical and translational research in osteoarthritis. He is the Florence and Cope Chair of Rheumatology and Professor of Medicine at the University of Sydney, Chair of the Institute of Bone and Joint Research, and Staff Specialist at Royal North Shore Hospital and North Sydney Orthopaedic and Sports Medicine Centre. He is ranked as the leading expert in the world on osteoarthritis on expertscape.com and is the section editor for Up to Date Osteoarthritis, the online medical information resource. He is also an editor for leading international journals in his field, has authored books on osteoarthritis, and has over 350 publications in peer-reviewed journals. Without further ado, I'll hand proceedings over to David. Thanks very much, David.
Thank you very much, Jen, and it's a great pleasure to be here tonight, and thank you very much for the opportunity to move. Thank you also everybody else for joining in, and I do hope tonight is both informative but also interactive, and that you come along and hopefully learn something from this that you can walk away with and hopefully help patient care as a consequence of that. Tonight, as Jen said, I'm talking about translating research into practice, and because my labor of love is osteoarthritis, that's pretty much what I'm going to focus on. I'm just pressing a couple of buttons here. Just firstly, by way of disclosure, my main funding comes from the National Health and Medical Research Council and also from Arthritis Australia, and I have worked for a couple of different companies. I think first and foremost, I'm going to concentrate on what osteoarthritis is, because I think there's a lot of misconceptions out there about this disease. Firstly, I think a lot of people historically thought that this was a cartilage-centric condition, and I think it's really important that people understand that the modern definition is one that this is a disease of the whole joint, essentially meaning that it can involve any of the synovial tissues within the joint, not just cartilage, but also bone, ligament, muscle, synovium and capsule, and obviously within the knee, the meniscus. Importantly, it presents with a person complaining of pain and limited function. So simply the damage to the joint is not a necessary, pain is not a necessary consequence of that. And there's a number of factors that provide some distinction between those two concepts. But from a clinician's perspective, I think the important concept here is that this is a disease, meaning it's a person who presents complaining of pain and limited function. It's incredibly common, and about 1 in 8 people within Western countries, including Australia, are affected by this disease. And it provides a huge individual burden to the people that are affected, and in addition to that, to the healthcare system. And this is a slide that was published back some time ago now, but essentially depicts the costs of osteoarthritis care. By far and away, the largest segment of costs relates to hospital inpatient costs for joint replacement. and then recovery and rehabilitation from that. And in 2012 in Australia, that was about $4 billion. That had increased 4 times since the year 2000. And for the average patient, that was about $1,600 per year. But a bigger cost relates to indirect costs. And I think, an important misconception here that should be laid to bed, that this is just a disease of older adults. About 2/3 of the people that have osteoarthritis are of working age, and this is the most common reason a person prematurely retires from the workplace, is because they've got osteoarthritis in a joint. And so the biggest cost related to osteoarthritis, so it's much bigger than the direct healthcare costs, are these indirect costs, and they largely relate to impacts on productivity and particularly to reduced employment. Now, firstly, just to introduce some of the work that we do, and then I'll focus a little bit more on tonight's presentation, but we do research into disease and pain mechanisms, to biomarker development, particularly centered around imaging biomarker performance. We do a lot of clinical trials on hands, hips, and knees, particularly in the field of what we call disease-modifying osteoarthritis treatment. So actually, treatments designed not just to modify symptoms, but also to modify the underlying structural course of the disease. Tonight's presentation will focus very much on health services, and each of the concepts that I've encrypted there will be mentioned, and we also do quite a lot of advocacy and policy work. This is the schemata for the presentation itself. I'm going to talk initially about prevention, then talk about guidelines and appropriate care, talk about some consumer-targeted interventions, and then looking at taking a clinical trial through to implementation and the effect it actually has on outcomes for consumers. Then looking at some new models of care, and then ultimately trying to do a bit of crystal ball stuff about where we might go next. Firstly, though, I want to talk about prevention. And the 2 biggest risk factors for osteoarthritis, namely obesity and joint injury, are both preventable and modifiable. And I think it's important that we pay appropriate attention to that, because right now this is a huge missed opportunity for people with osteoarthritis, is that we don't adequately do much in the way of either secondary or primary prevention. Similarly, we don't do much about impacting or altering the course of the disease itself through impacting progression rates by either reducing load on the joint or through disease-modifying agents or treatments. And again, there are huge missed opportunities there. And going forward, I think that's where a lot of interventions that we're currently developing will make a tremendous impact. I want this to sound a little bit pejorative and hopefully provocative to people who are managing osteoarthritis in the community. The way we currently manage osteoarthritis, I would best characterize as palliative. And that is meant to sound a little bit on the deleterious side, but essentially the most common modalities of treatment that are used to treat the average person that has osteoarthritis are simple analgesics, particularly paracetamol and anti-inflammatories. And when they don't work any longer, a person is referred off to see the surgeon. And I think it's important we recognize that joint replacement is a great procedure for the right patient at the right time. But the vast majority of patients who end up getting their joint replaced have never had any other appropriate conservative treatments before that time. And for the average person that has osteoarthritis, they have 2 to 3 joints that are affected. So simply by replacing one joint is not necessarily solving the problem. So this is what we do now, but ideally long-term, we should be able to do a lot more about impacting both prevention and progression. So talking about prevention in the first instance, as mentioned just a moment ago, the 2 biggest risk factors for osteoarthritis are overweight and obesity and joint injury. And overweight and obesity accounts for about 40 to 45% of a person's likelihood of developing osteoarthritis of the knee, and injury between 15 and 25%, 15% in women and about 25% in men. And as suggested, both of those are modifiable. So the overwhelming majority of people that have osteoarthritis, we could prevent their disease if we focused more on primary prevention. Unfortunately, at this point in time, we don't. But there are opportunities for us to do so. And from a prevention standpoint, and I'm not specifically going to talk about obesity prevention as a community, but there's a number of strategies that we have there, and I'd be happy to discuss those with you. But one thing that I think is eminently achievable for Australia as a community, it's been done well elsewhere, is what's called neuromuscular training. So every year, about 20,000 Australians tear their cruciate ligament, this ligament within the knee that helps to prevent translation of the tibia anteriorly on the femur. Most of them do it through non-impact injury. So basically the way they land and stand on their knee, producing forces within the knee that places the cruciate ligament that's susceptible to injury. That happens quite commonly in netball, soccer, the various other football codes, and it also appears to be more common in females, given the number of sporting participants. Now, doesn't matter what you do to the cruciate ligament once it's torn, about 70% of people will develop osteoarthritis within that knee in the next 10 to 15 years. The average age of the patient that tears their cruciate ligament is 20 to 25. So you can see this is impacting a large segment of the younger community, leading to long-term disabling consequences. And again, just to reinforce, even if you have that ligament reconstructed, it does not reduce your long-term risk of developing osteoarthritis of the knee. However, about 70% of these injuries can be prevented if people are given appropriate training programs. The training teaches people how to land on their knee properly, which is basically straight up and down, or with the knee in a slightly bow-legged direction, as opposed to the knee coming in underneath them in a valgus alignment. This places the knee at great risk of injury by landing on the knee in a direction like that. And so simply by teaching people and training them how to do that through programs like the FIFA 11 program or the PEP program, we can do that nationally. It's been done in other countries throughout the world, including Denmark and other Scandinavian countries, and has reduced injury rates in those countries by up to 70% when done well. You can see this could have a huge impact for osteoarthritis prevention, but unfortunately, Australia doesn't have the proactive leadership in the Ministry of Sport capable of making decisions that would actually favorably affect the Australian community in that regard. Moving on to management of osteoarthritis. This is a slide taken from the Osteoarthritis Research Society guidelines, which we brought out in 2014. So this is an international group responsible for osteoarthritis at a global level. They're probably the most widely cited and used guidelines, and largely I want you to focus on the top yellow box here, suggesting that for the overwhelming majority of people that have osteoarthritis, the core treatments should consist of exercise, weight management for those that are overweight or obese, and self-management and education. That should be the core treatments for the vast majority of people that have osteoarthritis. Unfortunately, about 70 to 80% of people who we end up seeing who've been on a waiting list for a knee or a hip replacement haven't had any of those treatments prior to getting there. There are a lot of other options that are available to people that have knee osteoarthritis, either those without comorbidities, which are very common in this patient population. So the comorbidities which are very common include high blood pressure, back pain, obviously obesity, as previously mentioned, heart disease, diabetes, depression, etc. But what we really worry about in this instance are particularly things like diabetes, cardiovascular disease, and a previous history of peptic ulcer, all of which should modify a person's treatment choices and should influence the rankings of these. So the benefit of this guideline is it broke those down to people that had knee osteoarthritis alone versus multiple joint osteoarthritis with or without comorbidities. And there's lots of different treatment choices that are available for every patient that has osteoarthritis. But we should start with these simple things first because they can make a tremendous difference. Unfortunately, the vast majority of patients who have osteoarthritis are not receiving appropriate care. This is a slide taken from the CareTrack study, which came out in 2012, and looks at the percentage of people with these various conditions receiving appropriate care. 100% is the ideal, and obviously treatment of coronary artery disease and stomach problems is pretty much close to that. However, osteoarthritis is way down here at about 40%, and if anything, I think this study is probably quite generous in the way it's categorizing appropriateness. So the picture is bleak, and we can obviously do a lot more to improve it. So where can we improve that particular context? So this is another study from the same group looking at areas where we're failing with regards to the management of osteoarthritis. In the first instance, we don't ask patients generally very well about their pain and functional status. So less than half of patients, we actually ask them about their pain and functional status. So we can obviously improve that. Close to a third of people are not offered any non-drug treatment. And by that, I'm talking about exercise, weight loss, use of shoes, braces, supportive devices, etc. So less than close to a third of people are actually being offered that, let alone it being delivered upon. Drug treatment is appropriate, again, in about 40% of people, but again, about 60% of the people, we don't do the right thing. And surgical referral, we're doing that more than these other particular categories. So I'd like to really highlight the fact that we should be asking people about their pain and function. We should be promoting non-drug treatment, and then if we do get to pharmacologic treatments, we should be actually promoting appropriate agents for the management of people with osteoarthritis. Now, most people who have osteoarthritis are not ready for surgery, but more often than not, that's all that's being offered to them. And that's the only referral or recommendation that's actually being made. And potentially as a consequence of that, most people who have osteoarthritis of the knee are not satisfied with their current treatment. So we know we can do better. So I think in that context, I think it's helpful for us all to reflect a little bit on what we're doing for our patients with osteoarthritis and whether we could improve that. And over many years and with interaction with a number of different consumers and health professionals, we've reflected on that and taken advice and feedback about how best to deliver care to the average patient with osteoarthritis of the knee. And this is a classic example. This is Barbara. She's a 65-year-old grandmother. She's got 6 grandchildren. She used to enjoy bushwalking, playing tennis, and she had to retire about 5 years ago from packing shelves in a supermarket as a consequence of her knee pain. Her body mass index is 29. The average body mass index of most patients that we see is about 32 to 33. And she has concomitant problems with blood pressure, and she's been experiencing pain in that knee for a number of years and wanted to get more actively involved in the management of it. And so went along to her local doctor and was advised to take some anti-inflammatories, which unfortunately made her blood pressure control more difficult. She went back and she had an injection into her knee of some viscosupplementation, hyaluronic acid. And again, it didn't provide her much of any sustained relief. So she went back again and she was referred to an orthopedic surgeon who wants to do an arthroscopy. And at that point, she's come along to see me, asking me about what else is there that I can do. So I'm going to talk a little bit about some of those interventions, the evidence base behind them, and what we probably should be doing differently with regards to management of osteoarthritis. But just to touch upon some of the interventions I mentioned along the way, we know that in a person who's got high blood pressure or who's got a previous history of peptic ulcer disease, that this is going to complicate management. So I think it's really important we be cognizant of that before we prescribe anti-inflammatories. Viscosupplements are no more effective than intra-articular saline. It's not to suggest intra-articular saline doesn't have an effect, but it doesn't cost anywhere near as much, and obviously it doesn't have the adverse event profile. And arthroscopy, we know, is probably more deleterious than helpful. In well-controlled studies, it has been shown to be equivalent to physiotherapy, to sham arthroscopy and some other interventions. So I think it's really important, and it's really beyond time, that we should be actively discouraging knee arthroscopy in the context of osteoarthritis. It doesn't help. It accelerates the rate of joint replacement and accelerates the rate of progression, and obviously puts a person at risk of complications. So it's time we stopped doing arthroscopies and stopped referring to surgeons who do them. Obviously, one way that we can help inform consumers about what's best for their osteoarthritis is by providing aids like My Joint Pain. So My Joint Pain is an initiative we set up with Arthritis Australia with the support of Bupa to help facilitate getting consumers more actively informed and aware and engaged with the disease. It provides a risk management tool to allow them to ascertain if they actually have osteoarthritis. It allows them to develop a personalized management plan. It gives them information about the disease, about management options, and then also allows them to link themselves with healthcare professionals that can help manage that condition that are in their local area, and also through social networking to communities of people that actually have osteoarthritis. So for any of you who are not aware of that, that's myjointpain.org.au. It's readily available and accessible in Australia and is free, and as I'll show you in the next couple of slides, I think it's helpful. It could be more helpful, and that's one of the areas that we're actively working on at the moment. So obviously, just because you build Rome doesn't necessarily mean that people are going to come there, and I think that's for a website. There can be a fantastic tool, and the best altruistic intent on our part doesn't necessarily mean it's going to make a difference. So we set about trying to evaluate whether this My Joint Pain was actually making a difference, and we looked at a number of different quality indicator items to ascertain if we make a difference in people who use My Joint Pain after they've used it for a period of time. And you can see here for a number of these quality indicator items that there was some improvement in self-management, in lifestyle management, and in physical activity after people had been exposed to My Joint Pain for a 12-month interval voluntarily. We also compared them to a group of controls who hadn't been exposed to My Joint Pain and found, again, that there was some improvement in self-management rates, again, small, but statistically significant, and also in weight reduction, again, small, but statistically significant. Obviously our challenge was that there were suggestions here that there were improvements, but we probably weren't really getting the traction we wanted and the engagement we wanted. We looked at a number of other domains related to health education impact to see if we were making a difference to a number of different domains. And for all of the domains, we can see here that there is an improvement in people that have used My Joint Pain. And just so you're aware, for those people who are questioning that there was an improvement, just for emotional distress, this particular item is flipped. So for all of the items, we're seeing an improvement. But again, like we saw for the quality indicators, the improvements are small. Another really important element that I do want to focus on just for a couple of minutes is the importance of overweight and obesity, which is so prevalent in our community. And from a primary prevention perspective, as mentioned before, something ideally we should be doing a lot more about. Why? Well, this is a study looking at the impact of diet and exercise in an overweight, obese population with knee osteoarthritis. Over the course of an 18-month intervention, these people lost 10% of their body weight through a combination of diet and exercise. With that 10% weight loss, their symptoms improved by 50%. So again, just to reinforce, overweight and obese with knee osteoarthritis lose 10% of your weight through diet and exercise, symptoms can improve by 50%. To put that in the context of the average anti-inflammatory improves a person's symptoms by about 20 to 25%. So we can make a huge difference by getting people to lose weight through diet and exercise. Now, you're going to say to me, well, that's fantastic, David, but can you do that in the real world? Well, this is an Australian-based study from Healthy Weight for Life, which is an accessible intervention to anybody in the Australian community and is paid for by most of the major health insurance companies. And we did an evaluation of their data late last year, and this was recently published. And this was largely led by one of my PhD students, Inoshi. 1,400 Australians have a mean BMI of 34 and moderate degrees of pain and dysfunction. And over the course of a 4-month intervention, on average, these people lost 7.5% of their body weight, leading to clinically important improvements in pain. I think the important point to make here is this is less than 2.5% weight loss. This is 10% weight loss. So the vast majority of people sitting in this category, so 24%, 22%, 31%. So most of them lost more than 5% of their body weight. And this is the clinically important change or threshold in their KOOS score. And you can see the dose-response relationship. So essentially, the more you lose, the more your symptoms are going to be able to improve. So it's critical for the overweight, obese person that has osteoarthritis, we get them to lose weight because we're going to see measurable improvements in their pain and function. And this is, this Healthy Weight for Life program is a program that's readily available to Australian consumers. So a lot of people say, well, yeah, we can't do it. This shows that we can, as long as we give the people, the patients, the consumers, the tools to enable them to do it. Another effort that we've gone to over recent years is to develop what's called the Osteoarthritis Chronic Care Program. So I led a team with the Agency of Clinical Innovation to develop this model of care, which is based in tertiary referral hospitals in Sydney. And in the first instance, came out of focusing on people who are on the waiting list for a knee or a hip replacement. Over the last 4 years, we've treated in excess of 10,000 patients at now 14 hospitals, and we've recently rolled this out to a private hospital as well. It consists of multidisciplinary coordinated chronic disease management, focused very much on the consumer, but providing them opportunities to do exercise, to lose weight, to use assistive devices, to modify their medication through interactions with multidisciplinary clinicians. And it's making a big difference to not only health outcomes, but also health service utilization. About 15 to 20% of people who were on the wait list for a knee or hip replacement decide to come off this wait list voluntarily because of improvements that they feel after being involved in this 12-month program. And a lot of people will say, well, that's great, you can do that in New South Wales, but there's no reason why it can't be done in other parts of Australia as well. So this is, as I said, the Osteoarthritis Chronic Care Program, about 10,000 people since 2001. There's more information on that URL, and I understand that these the slides and the presentation will be available to you after this. And it's funded through the public hospital system. And because of the benefits that the public hospitals seen in terms of cost shifting, whereby, for every $1 that is invested in the local health district, about $5 is shifted away from joint replacement and rehabilitation costs. So it saves them a lot of money. A lot more hospitals are beginning to be interested and focused on that. Now, a lot of people get really concerned with guidelines, and they say, well, guidelines are just a long list of recommendations that I can't apply to the individual that presents to me because they're so different from the type of patient that you're thinking about when you're critically evaluating and developing those guidelines. So again, with the help of a wonderful postdoctoral scientist who works with me, Sarah Menezes, we recently went through an effort to try to develop some patient-centered algorithms for hand, hip, and knee osteoarthritis to give clinicians tools to allow them to think about, okay, so this intervention option is not suitable in that patient. What else can I do? And also to hierarchically categorize the treatments into what you should be thinking about doing first. That was published again earlier this year. And again, it's just an effort to try to translate evidence-based care into practice using tools, in this instance, algorithms, to facilitate health professionals making judicious decisions that they can get involved in patient-shared decision-making with. Another effort, a little bit like this one tonight, that we've been using to try to inform both health professionals and consumers is getting a little bit more of a social media presence. So through the Institute of Bone and Joint Research at the University of Sydney and the Colling Institute in Sydney, we've established a Facebook site. We have the Colling Institute in Sydney. We've established a Facebook site. We have Twitter feeds, a blog. And we've primarily done it because I think it's not only helpful for recruitment and building a community base, but also to help engage with consumers, to inform them about different treatment options. And to that end, we're running monthly webinars for consumers that have been pretty well attended thus far over the last several months. And again, you can find more details on the Institute of Bone and Joint Research homepage. And again, I'm not a Facebook person, and I'm born in a previous century. And people know more about social media than I, but I think it's a great tool for engaging consumers, health professionals, and also allowing people to follow the activities that we're doing. So where are we heading? Well, obviously we've done a lot with regards trying to get consumers more involved and engaged, and we'll continue with a lot of those efforts. And we're trying to develop some more engaging apps that will be stickier and get people to come back and engage. We've also developed obviously some health service delivery plans that to date have largely been hospital based, and that's in part a consequence of the fact that that's where I work, but obviously the patient population is largely in the primary care setting. And so I think in an effort to try to get out there to consumers in primary care, we're now in the process of developing a GP model of care called Partner. We've recently just been funded through the NHMSE partnership scheme in concert with most of the major health insurers and a number of other stakeholder organizations to develop this model of care, which will consist of modifying the electronic medical record for GPs, developing some educational tools, doing some audit with GPs, and then facilitating referral of appropriate patients to a centralized remotely delivered service called the Care Support Team. And through that, we'll give patients exercise, we'll get patients to lose weight, we'll get them to get appropriate medication advice. And it's really about trying to make the life of the GP as simple and straightforward as possible, and to provide evidence-based care remotely. And then where needed, to link to other health professionals in that person's local community that will help to facilitate providing evidence-based care. It's a study that we're in the process of developing and delivering at the moment, and we should see results of that within the not too distant future. I'd again like to thank Move for the opportunity to speak with you tonight. I'd also like to thank all of you for hopefully paying attention during the course of this evening. I think there are hopefully some questions appearing in the box as we're going along. And just in closing, just to reinforce the point that as a clinician researcher, I feel privileged to research what is an incredibly disabling disease, something that I have, but one where there's such opportunity for advance and such opportunity for improvement. We are currently using a lot of diverse strategies to facilitate improving disease management, but I think there's a lot more that we can do. And going forward, we're going to focus a lot more on consumers and actually what's happening in primary care. Again, I'd just like to thank you for the opportunity to present to you tonight and for listening, and I'd like to open it up to questions, if there are any.
Thanks very much, David, for a very comprehensive presentation that really, for people who may not have heard of some of those issues before, certainly raised some very important issues in the sort of the prevention and management of osteoarthritis in Australia. While we're waiting for any questions that may hopefully appear, I'm interested that you mentioned your partner project just at the end there. I was wondering whether you had actually done any research with regards to some of the reasons why, as you pointed out, 78–80% of people who were referred for a replacement actually hadn't received any of those core treatments. So what were some of the factors, if you had looked into those, as to why that was occurring?
Yeah, I mean, so I think, you know, a lot of the behaviors that we're trying to modify in partner really are targeted towards getting people more appropriate care before they get referred off for a joint replacement. And so some of those behaviors are really centered around, you know, how do we make a diagnosis of osteoarthritis? So it's a clinical diagnosis. It's based on, you know, a person's presenting pain, function, and symptoms consistent with the diagnosis of osteoarthritis. Imaging can be used to confirm that diagnosis, but oftentimes is actually unhelpful. And, you know, in the context of osteoarthritis, what I'm really there focused on is if we get a lot of patients to have MRIs of their knees, the average person who's over 55 in the community without knee pain will have a tear of the meniscus. So we know that in people without pain, without osteoarthritis. So if we do that in people that have osteoarthritis, they will uniformly have a torn meniscus. It's not responsible for why a person presents complaining of pain and limited function. But unfortunately, if they have an MRI, they see they have a torn meniscus, a lot of them will then go on and see a surgeon and want to have something done about that. So starting with diagnosis, I think it's important we pay attention to that. Another key behavior that we want health professionals to focus on is you know, promoting the idea that exercise and physical activity is key and essential for most patients' management with osteoarthritis. Another important element is getting people to pay attention to weight. I don't think a lot of consumers and a lot of health professionals pay appropriate attention to weight. And so in that context, getting people to pay appropriate attention to measuring weight and doing something about it, as opposed to just mentioning that you're overweight and obese and you've got to lose weight, but actually providing consumers the tools to facilitate them losing weight and becoming more engaged. So there's some of the key behaviors we're focused on, and then obviously making the appropriate referral. And, you know, in this instance, thinking about referrals for exercise, for weight loss, for appropriate conservative, often non-pharmacologic management. We know, you know, the number of referrals to orthopedic surgeons dwarfs the number of referrals to physiotherapists and dietitians for this disease. And so we need to redress that balance. And it's not, again, just to reinforce, I'm not against joint replacement. I think but it needs to be the right person at the right time. And, you know, the most common elective orthopedic procedure that people with osteoarthritis have is an arthroscopy, and we know that makes people worse. So there's some fundamental problems with the delivery of our health service. Part of that comes from referrals, and that's something we're actively trying to address. Now, I can see a couple of questions popping up there in the chat box, so I might move on and start talking about those. And for anybody else who has questions, please obviously feel free to write them in as we go along. The first question is, has there been any further update into the most effective type and amount of exercise? And, you know, I think there are a number of key messages I want to give here. So there have been a number of studies comparing supervised exercise to home-based exercise to the sheet of exercises to group exercise. And we know that supervised exercise is probably the most effective type of delivery. So that's one-on-one, which is better than group exercise, which is better than home exercise. And, you know, if you just give a person a sheet of exercises without any technical instruction, without any reinforcement, we know that that's completely ineffective. So I think that's one important point to make. Second point to make is it appears that strengthening exercise is critically important to the function of joints, and the more strength a person gains, the more their function is likely to improve. We tend to focus very much on strength of the muscles on either side of the joint that is affected, and particularly on muscles that cross the joint that is affected. So we know that strengthening exercises are helpful. And I'll get on to a little bit more detail about what types of strengthening exercises in a second. And we also know that cardiovascular, aerobic conditioning is also critically important here. And ideally, that aerobic cardiovascular conditioning should be performed up to College of Sports Medicine recommendations, so 30 to 45 minutes most days of the week of exercise, and should be ideally low impact exercise. So what we're talking about there are things like swimming, walking, cycling, Tai Chi, using a cross trainer type machine, as opposed to running, tennis, basketball, which are much higher in impact and potentially likely to be deleterious to the joint long term. So just coming back and talking a little bit about specific strengthening exercises, because I think, oftentimes it's challenging for people to do strengthening exercises, particularly given sometimes that exacerbates symptoms. I think it's important we identify, particularly for knee osteoarthritis, what part of the knee is principally involved. Is it the patellofemoral joint? Is it the medial tibiofemoral or the lateral tibiofemoral joint? And modify our exercise prescription according to which muscles are principally involved. If it is the patellofemoral joint, don't do a lot of heavy loading and lifting with the knee in a flexed position beyond about 30 degrees of flexion. Try in the first instance to focus on particularly quadriceps strengthening and also hip abductor external rotator strengthening to reduce femoral internal rotation, with the knee not going into more than about 30 degrees of flexion, simply because beyond 30 degrees of flexion, the patella will be in the femoral trochlea and it may exacerbate a person's symptoms. For a person who's got medial tibiofemoral osteoarthritis, oftentimes we want to focus, again, very much on quadriceps strengthening, but in the first instance, try to give the hamstrings some attention. And in addition, again, focus on the hips, particularly the abductors and external rotators, and try to get people to reduce what's called the adductor moment, which is the dynamic varus thrust that people often have in the context of knee osteoarthritis. Very happy to take other questions about exercise if people have questions about exercise, but I'm just going to move on and talk a little bit about the next question. Firstly, clients are reluctant to accept walking aids. Any suggestions? So yeah, it's a common problem, and I think when you mention walking aids, you're probably talking about a walking stick or a cane, and obviously more people these days are also using ski poles and the Nordic poles that people may be more familiar with seeing in cross country. And sometimes, I think it is challenging to get people to use those, but I think it's important that people recognize that there is good evidence to suggest that will improve a person's symptoms, it will reduce load on the knee. And we're currently in the process of doing a study with the University of Melbourne, looking specifically to see whether we can actually modify the structure by unloading the knee using a cane. I think in the first instance, it's important we give people the opportunity to make a decision whether they want it or not. Give them the appropriate advice about how to use a cane. Obviously, in the hands contralateral to the joint that's affected through mid-stance on the other side, so that you're actually unloading the joint. But if we don't give the people a chance to make a decision, then they won't pick it up. Similarly, if we discourage them from using aids like that because of their appearance, then they're actively not going to want to pick them up. But at least if we give them the chance, they can hopefully take that chance and run with it. A lot of people won't necessarily want a walking aid because of, I guess, the appearance that walking aid carries with it. But I think it's important we offer it to them. Recognize that there are lots of other alternatives to walking aids for treatment. And in that context, I think a lot of people probably haven't thought enough about the use of shoes and other motion control devices in and around joints. So there I'm thinking particularly about braces that may actually help unload parts of the knee. So there are lots of devices that are available to actually help modify symptoms, many of which have been demonstrated to be helpful in this context. And again, unless we offer it to patients and unless they're given an opportunity to decline that, it's very challenging to know whether they're going to be accepting of that or not. But at least if we make the offer, it's there.
Yes. And David, just on another note, I have just a query, you sort of raised the issue there in relation to your various initiatives looking at consumer knowledge and also sort of, I guess, practitioner knowledge and skills. How much do you think that sort of patient or consumer expectations often will be influencing health practitioner sort of response to a presentation of pain and lack of function, obviously indicating possible osteoarthritis?
Yeah, so I think consumer expectations, consumer participation, consumer engagement, and knowledge and education all play critical roles in both the outcomes for treatment and the interventions they take up, and, as you've suggested, Jen, their interactions with healthcare professionals. And I think also the healthcare professionals' perceptions of what the consumer's expectations are also play a critically important role here. So I think it's really important to go in with as blank slate as possible. And I think to give the consumer the opportunity, the tools and the knowledge that they can go out and identify what are the various evidence-based treatment options for the management of my problem. And that's obviously something we've tried to do with my joint pain, is to give them the tools so they can actually develop individualized tailored management plans. And also within that, build a decision aid so they can hierarchically look at the prioritization of different treatment options according to their preferences. It may be that they don't want an injection. It may be that they don't want a pill. It may be that they don't want to exercise. And so I think it allows it to tailor it a little bit to them. So I think as best you can, try to go in with a relatively blank slate. Try to reduce preconceived notions about what patients want, and give them an opportunity to also participate in that decision-making process, because I think oftentimes our expectations of what they want are often completely misplaced. I think a lot of people feel that, I can't talk to a person about their weight. I can't talk to a person about getting them to be less sedentary because they're just not going to be accepting of that. But it's surprising what happens when you actually engage them in that conversation and relay to them the importance of doing so. Just tell them, if you lose 10% of your body weight, you can expect a 50% improvement in pain. If you, improve your knee strength, you can expect a commensurate improvement in your function. So, those simple things I think are really important. You set tangible goals with the patients that are meaningful to them, and go about attaining them. Because even for the most structurally damaged knee, there's usually something that you can do that is quite meaningful to their long-term care and health.
I'd like to encourage, yes, I was going to say we've got one question here, and I ask other people to type any questions in, because we will we'll make this the last question that David will respond to, unless people type in their questions now. So over to you, David, for this last question.
Yep, thanks. Do you have a recommendation regarding taping for knee osteoarthritis? So there are a number of trials, including again one from the University of Melbourne, that has demonstrated the efficacy of taping in the context of knee osteoarthritis. Interestingly, the trials were not isolated just to people that had patellofemoral osteoarthritis, but included people with tibiofemoral osteoarthritis as well. But despite the fact that the tibiofemoral osteoarthritis was present, most of these patients still improved irrespective. And the taping program that was applied here was the McConnell taping program, which is essentially applying a medial glide typically across the superior pole of the patella to reduce what more often than not is lateral patellofemoral joint involvement in the context of osteoarthritis. Oftentimes patients here will have quite a degree of patellar tilt, and so try and align and orient your tape so that it tries to correct that. For a lot of patients who have osteoarthritis, they will redeem a benefit, and you can obviously, as a clinician, ascertain whether that's true and accurate by their application and doing a functional task without the tape on to ascertain if their symptoms are improved. I think the long-term challenge here is adherence to tape and whether there are other more practical alternatives to tape, such as patellofemoral sleeves, weight loss, using, particularly in the context of patellofemoral osteoarthritis, considering in a person that's got an overpronated foot disposition, an insert into their shoe or a motion control shoe, and also paying a lot of attention to excessive femoral internal rotation, which is incredibly prevalent in the population of people that has patellofemoral osteoarthritis. So I think paying attention to all of those factors is critical, but taping, again, can play a really good and important role here, and I'd encourage all clinicians who haven't necessarily learned about patella taping to become familiar with it. Again, if that's the last question, thank you all for listening, and thank you to Move for the opportunity to speak with you all tonight.
And many thanks to you, David, for your presentation this evening. And I'd also like to thank those people who have joined the webinar tonight. And we ask that you consider joining us for our next webinar on Monday, the 14th of November, which will be on pain management in the primary healthcare sector. So once again, many thanks, David, for your great presentation this evening, and I wish everyone a good evening. Good night.